We've already discussed some of the commonly tested conditions associated with the acute abdomen, and we will now continue on and finish this broad subject. First, let's tackle abdominal abscesses and then move on to inflammatory conditions of the GI tract, as well as bowel obstruction. Let's get started with another case. A teenaged boy comes into the office with right lower quadrant pain. Pain started yesterday, but has changed from a vague mid-abdominal pain to a sharper pain. He has exam findings of guarding, rebound tenderness, and if you push on the left side, it hurts on the right. He also has an elevated white count. What is the next step in managing this patient? Is it A, abdominal x-ray, B, colonoscopy, C, right lower quadrant ultrasound, or D, laparoscopic appendectomy? This patient has classic appendicitis. The pain is in the correct location at McBurney's point and has changed location. He also has peritoneal signs as well as a positive Rosving sign, which is right lower quadrant pain with palpation of the left lower quadrant. And appendicitis is most often seen in late teens and young adults. In a case such as this, when the diagnosis is so clear that it leaves no doubt as to the cause of the patient's symptoms, a laparoscopic appendectomy is warranted, even without radiographic evaluation. In a male patient with classic symptoms in the correct age group, you don't even need a CT scan, the diagnostic test of choice, before surgery. However, if CT were an option, you could choose it as well. Abdominal X-ray findings are nonspecific for appendicitis and would not be helpful in this situation. Not only is a colonoscopy too invasive for diagnosis, but as mentioned previously, it could perforate the inflamed bowel. And finally, right lower quadrant ultrasound may be helpful in a female patient to rule out pathology in the reproductive organs, but ultrasound findings are nonspecific for appendicitis. Let's take a step back and review the differential diagnosis and treatment options of the different causes of right lower quadrant abdominal pain. If you get a question about right lower quadrant pain, and you will likely see at least one on test day, the first additional piece of information to consider is age. While there are many causes of right lower quadrant pain, very few affect the elderly. One that does, that is periodically tested on step 2, is cecal diverticulitis, a rare variant of the more common sigmoid diverticulitis. If presented with right lower quadrant pain in an older patient, you should consider cecal diverticulitis as the likely diagnosis and treat with bowel rest, an NG tube placed to suction, and broad-spectrum antibiotics to prophylactically treat for an intra-abdominal infection that could result if the diverticulitis progresses to a true bowel perforation. If you are dealing with a younger patient, the next thing you should note is the gender. If the patient is male, you can disregard all gynecologic causes of right lower quadrant pain and confidently diagnose appendicitis. Again, as just discussed, the definitive treatment for these patients is an urgent laparoscopic appendectomy. Conversely, if the patient is female, you must order a urine beta-HCG to ensure that the patient is not pregnant. A pelvic ultrasound should also be performed to evaluate for an ectopic pregnancy. Remember, never do a CT on a premenopausal female unless you have confirmed that she is not pregnant. If either of these tests is abnormal, an ectopic pregnancy is likely, and these patients must be treated surgically to prevent a life-threatening rupture of the fallopian tubes. If the pregnancy test and ultrasound are normal, your young female patient likely has appendicitis, but you must rule out ovarian torsion first. This is done via Doppler ultrasound, which can assess blood flow to the ovary. If torsion is present, an emergent laparoscopic surgery must be performed in an attempt to relieve the vascular abnormality, reestablish blood flow, and hopefully salvage the affected ovary. Abdominal abscesses are another commonly tested cause of abdominal pain. In practice, the most common cause of these discrete intra-abdominal infections is a complication of abdominal surgery, in which an undrained fluid collection left in the abdomen becomes infected. However, inflammatory diseases of the bowel can also lead to abscess formation, as microscopic perforations in the bowel wall can provide bacteria in the gut access to the peritoneal cavity. And finally, abscess can also result from penetrating trauma. There is no classic sign or symptom seen with an abdominal abscess. Rather, you must have a high index of suspicion based on the patient's recent medical history and the constellation of presenting symptoms. Frequently, abdominal abscesses cause pain, and when they grow large enough, can also cause distension of the abdomen as well. As with all infections, these patients also develop systemic symptoms, including fever and chills, as well as GI distress. And finally, if the abscess is located in the lower abdomen, it can press against the distal large bowel, causing a sensation of rectal pressure. The diagnostic test of choice for an abdominal abscess is an abdominal CT scan, which not only can identify the location of the fluid-filled abscess, but can provide vital information about the surrounding anatomy, which is necessary when it becomes time to drain the abscess. Here is an axial CT cut of the abdomen in a patient with an abdominal abscess. Note the presence of a distinct air fluid level depicted by the arrows. There is also a well-circumscribed rim around the region, which should raise your suspicion for the presence of an abscess. As you might expect in the presence of an infection, a CBC will also likely show leukocytosis. Treatment of abdominal abscesses, and in reality all abscesses within the body, require a two-pronged approach. First, antibiotics must be given to fight the infection. Abscesses are often polymicrobial, so a broad-spectrum antibiotic should initially be chosen and can be narrowed as culture results return. Unfortunately, these pockets of infection often have thick walls that are poorly penetrated by antibiotics. Thus, abscesses must also be drained to remove the nidus of infection and allow antibiotics access to the infected tissue. This can be done either via an open surgery or, if possible, a CT-guided percutaneous drainage procedure. To introduce the next topic, let's discuss another case. An elderly woman presents with left lower quadrant pain, fever, and decreased appetite. She has a history of dark, tarry stools and takes stool softeners and iron supplements. On exam, she has abdominal rigidity and guarding. What is the most likely diagnosis? Is it A, ectopic pregnancy, B, acute appendicitis, C, cholecystitis, D, acute diverticulitis, or E, acute pancreatitis? Based on the information presented in the question stem, this woman has evidence of diverticular disease. She has two major risk factors for this condition: old age and a history of constipation, as evidenced by the fact that she takes a stool softener. Though she has never had overt symptoms of diverticulitis before, the episodic melena that was described may be secondary to diverticulosis, which can present with bleeding, as well as anemia, which is likely the reason that she has been prescribed an iron supplement. Bloody stools in the elderly are cancer until proven otherwise, but in this case, she presents with acute symptoms consistent with diverticulitis. Ectopic pregnancy can cause left lower quadrant pain, but not in a postmenopausal patient. Acute appendicitis is most frequently seen in younger adults, and the pain is located on the right side of the abdomen. Cholecystitis presents as right upper quadrant pain. And finally, acute pancreatitis localizes to the mid-abdomen with radiation to the back, and neither pancreatitis nor cholecystitis would be associated with a history of melena. This is a very dense slide, but an incredibly important one for your Step 2 CK preparation, because it details 4 of the most commonly tested topics from the surgery section. You will not only be expected to quickly identify each of these inflammatory conditions based on the presenting symptoms, but will also need to know why they arise, as well as how each is best diagnosed and treated. Kaplan has created the following graphic chart to help you remember each of these details and to allow you to compare and contrast these extremely high-yield topics. A common theme for the cause of each of these diseases is obstruction, leading to upstream infection and inflammation. When any luminal structure becomes obstructed, the fluid proximal to the obstruction cannot pass, leading to the formation of a static fluid collection, the perfect breeding ground for a bacterial infection. As the infection festers, it causes inflammation of the surrounding tissues, at which point the patient will start to become symptomatic. With appendicitis, a fecalith, which in effect is just a compact nugget of stool, gets stuck in the opening of the appendix sac, which leads to inflammation of the appendix. In pancreatitis, alcohol abuse is the most common cause of chronic pancreatitis, and it is thought that alcohol leads to premature activation of pancreatic enzymes within the pancreas. The most common cause of acute pancreatitis is impaction of a gallstone into the pancreatic duct, preventing the passage of pancreatic enzymes. Diverticulitis is functionally very similar to appendicitis and is again secondary to impaction by stool, this time by occluding the opening of a diverticular sac in the bowel wall. And finally, cholecystitis occurs when a gallstone obstructs the cystic duct, which prevents bile from exiting the gallbladder. The symptoms of each condition are similar, so I'll focus on the unique features of each. Appendicitis is almost always accompanied by anorexia, so if a patient denies loss of appetite, they likely don't have appendicitis. As expected, they also have a fever secondary to inflammation. The pain pattern is very specific in appendicitis. Initially, the patient experiences visceral pain from the appendix itself, which enters the spinal cord at the T10 level, and thus is experienced as pain in the periumbilical region. Once the appendix becomes grossly inflamed over the next 12 to 24 hours, the location changes to McBurney's point in the right lower quadrant because the peritoneal wall becomes irritated at this spot after coming into contact with the inflamed appendix. Pancreatitis also causes nausea, vomiting, fever, and pain, but the pancreas is a retroperitoneal organ, and thus pain is referred to the back. With diverticulitis, which most commonly affects the sigmoid colon, pain is felt in the left lower quadrant, the location of the sigmoid. And with cholecystitis, the patient will again complain of nausea and fever, but the pain will be located in the right upper quadrant, where the gallbladder lives, and they may also report a positive Murphy's sign, which is pain with deep breathing that occurs because inspiration causes the peritoneal wall to come into contact with the inflamed gallbladder. As we previously discussed, diagnosis of appendicitis can be made solely based on physical exam, but the best confirmatory test is a CT scan. CT scan is also the diagnostic test of choice for pancreatitis, but you will also see elevated blood amylase and lipase levels, since these pancreatic enzymes are obstructed from entering the intestines and thus are partially absorbed into the bloodstream. An elevated lipase level is considered the more specific sign of pancreatitis than an elevated amylase. CT scan is also the best test for noting the presence of diverticular outpouchings within the large bowel and inflammation of the bowel wall. CT is not the diagnostic test of choice for cholecystitis, however, which instead should be initially worked up with an ultrasound. The classic ultrasound findings of cholecystitis include pericholestatic fluid, a thickened gallbladder wall, and in some, but not all cases, stones in the gallbladder lumen. If the diagnosis is in question, a nuclear medicine test called a HIDA scan can confirm the diagnosis. Treatment of appendicitis requires surgical removal, and the procedure of choice is a laparoscopic appendectomy. Pancreatitis is a non-surgical condition, as the pancreas is a difficult organ to operate on, and therefore it must be managed medically with aggressive IV fluids and bowel rest. Management of diverticulitis changes based on how many times the patient has experienced a flare of this condition. If it is the first bout of diverticulitis, most surgeons prefer to treat the patient medically with antibiotics and bowel rest. However, if the condition recurs multiple times, it is an indication for a resection of the affected bowel. And finally, cholecystitis is best treated by laparoscopically removing the gallbladder. Unfortunately, despite the frequency with which each of these conditions is seen and the routine nature of treatment, each inflammatory condition presents the potential for complications. Appendicitis can progress to formation of an abscess, which must be drained either percutaneously or surgically. An unfortunate sequelae of pancreatitis is the development of a pseudocyst, which arises about 6 weeks after a bout of acute pancreatitis and must either be drained or removed. These patients can also develop hemorrhagic pancreatitis, as was discussed in our previous lectures. Diverticulitis can also lead to abscess formation if an inflamed diverticula ruptures. And finally, an inflamed gallbladder is at risk for perforation, which can lead to a bile-induced peritonitis. With that very high-yield slide out of the way, let's discuss one more condition and introduce it with our final case for this session. A middle-aged man comes to the emergency room with abdominal pain and GI complaints. He has not had a recent bowel movement. Medical history is significant for diabetes and a previous abdominal surgery. He is febrile to 101.8, and physical exam reveals high-pitched bowel sounds. An abdominal x-ray is shot and reveals a partial small bowel obstruction. What is the next step in the management of this patient? Is it A, prescribe a laxative, B, place an NG tube, C, emergent surgery, D, antibiotics, or E, colonoscopy? This is one of those obnoxious step 2 style questions where the STEM spends a long time describing a patient's presentation, but ultimately tells you what the diagnosis is in the last sentence. Be on the lookout for this format because you can save a lot of time by jumping directly to the question in certain situations. Here, they're interested in the early steps in the management of a small bowel obstruction, and an important consideration is that an NG tube must be dropped and placed to suction in an effort to empty the gastric contents and relieve the pressure that is building up in the bowel. A laxative would actually serve to increase the pressure in the bowel, and as such, increases the risk of a serious complication such as ischemic necrosis or bowel perforation. While surgery may ultimately be necessary, especially if the obstruction progresses to a complete obstruction, it is not yet indicated in this patient who only has a partial obstruction and has not yet tried medical management. Antibiotics would be warranted if the bowel perforates, but we have no reason to assume that it has at this time. And finally, a colonoscopy would not be able to relieve an obstruction in the small intestines and could make things worse. While there are many potential causes for a bowel obstruction, the most important of which will be discussed on the next slide, the common final pathway is that an obstruction leads to the accumulation of bowel contents proximal to the site of obstruction. As more and more fluid and gas accumulates, and especially if the bowel continues to peristalse and further push against the obstruction, the intraluminal pressure will increase, leading to severe abdominal pain. Furthermore, pressure on the bowel can also lead to decreased perfusion to the capillaries of the intestinal mucosa, which can lead to tissue ischemia and necrosis. Obstructions can be either partial or complete, with the important difference being whether or not the contents of the bowel have any route of passage beyond the obstruction. If not, the pressure increase occurs at a much faster rate, and because there is no release valve, a complete obstruction represents a much more serious problem. Of the many potential causes for a bowel obstruction, the most common in the developed world is adhesions from previous abdominal surgeries. These adhesions are effectively scar tissue within the abdominal cavity, around which the bowel becomes twisted, leading to obstruction. In underdeveloped countries in which abdominal surgeries are less common, hernias represent the number one cause for bowel obstruction, as the bowel becomes caught in a hernia sac. Large bowel obstructions are commonly due to either a cecal or sigmoid volvulus, in which the bowel twists on its own mesenteric roots. Crohn's disease leads to transmural inflammation of the bowel wall, which in turn causes adhesions and strictures. Note that ulcerative colitis does not predispose to a bowel obstruction because the inflammation is confined to the mucosa. Large neoplasms can grow into the bowel lumen, also leading to obstruction. The final three conditions on this slide are common causes of bowel obstruction in children and will be discussed at length in your pediatrics review material. In brief, intussusception, or telescoping bowel, can lead to obstruction due to compression of the inner segment of the bowel by the outer segment. Foreign bodies, if large enough, can become lodged in the small bowel lumen. And finally, in neonates, a congenital abnormality that leads to intestinal atresia often presents with the symptoms of a complete bowel obstruction. As was briefly reviewed in the previous case, The symptoms of a bowel obstruction include a crampy abdominal pain that is not localized to any particular quadrant, but instead is diffuse. It is also colicky in nature, meaning that it comes and goes, which is true of any pain that is secondary to an obstruction. Think of the colicky flank pain secondary to obstruction of the ureter with a kidney stone. Because gastric contents become backed up, these patients will also experience nausea and vomiting, and may develop a fever secondary to inflammation. And finally, on auscultation, you may hear a high-pitched tinkling sound, which indicates that the air present in the bowel is under high pressure. Diagnosis of a bowel obstruction is suggested by labs and confirmed by radiology. Common lab findings that suggest a bowel obstruction include leukocytosis, as well as a lactic acidosis that results from poor perfusion of the bowel, secondary to the elevated intraluminal pressure. Diagnosis is further suggested by an abdominal X-ray, showing the classic findings of air fluid levels and dilated loops of bowel. This X-ray displays a small bowel obstruction. First of all, note how much air is present in the intestines and the large diameter of the bowel. This distension is secondary to the pressure increase in the bowel as a result of the obstruction. You should also note the distinct horizontal lines found all over the X-ray. These are air fluid levels and result because fluid, which becomes stuck in the bowel due to the obstruction, is pulled by gravity to the dependent part of the bowel, forcing air to rise to the top and creating a boundary between the air and fluid in each particular segment of the bowel. While labs can suggest a bowel obstruction, and an X-ray should be ordered initially to help make the diagnosis, the gold standard study to diagnose a small bowel obstruction is an abdominal CT scan with oral contrast. The contrast will accentuate the intestinal wall, making it easier to differentiate bowel from other abdominal structures. Because of the increased clarity that CT can provide, you can often actually pinpoint the location of the bowel where the obstruction occurs, because there is a transition point where the proximal bowel is large and dilated and the distal bowel is small and decompressed. In terms of treating bowel obstructions, the management algorithm is actually very similar to treating a gastric perforation, as we discussed earlier, but with a few important differences. Again, the very first thing that must be done with these patients is that they must be prevented from eating. Otherwise, they risk further increasing the intraluminal bowel pressure, as well as the potential for ischemic necrosis and bowel rupture. And again, an NG tube must be inserted and placed to suction in an effort to decompress the bowel proximal to the point of obstruction. These patients also require IV fluid resuscitation, but this time it is not in preparation for surgery, at least not necessarily. Due to the pressure increases in the bowel, much of the intravascular fluid enters the extravascular compartment, leading to clinically significant hypotension. Thus, IV fluids must be given to maintain blood pressure. Often, this is sufficient management of a bowel obstruction, and over the course of a few days, the obstruction will resolve itself. However, there are certain indications to proceed with surgical decompression of the obstruction. First, and most importantly, if the obstruction is deemed to be complete, the risk of progression to ischemic necrosis and perforation is significant, and thus these patients must have an emergent exploratory laparotomy to evaluate the bowel, relieve the obstruction, and resect any necrotic areas. Also, if the symptoms associated with the partial obstruction have not improved over the course of 3 to 4 days, it is possible that the underlying cause for the obstruction will not resolve itself and must be corrected surgically. Alright guys, I know this was a long 2-part lecture, but this material is the bread and butter of general surgery, and thus will be a heavy focus of your test. Make sure to spend some time reviewing these concepts, and you will be glad you did when you sit down to take your Step 2 CK exam. Next time we will be tackling the final section of your surgery prep material, and the subject will be orthopedic injuries. Thanks everyone, and keep studying hard.